Hello and welcome to KYSCO Oncology Voices, bringing you the latest in Kentucky cancer care. Happy 2026. My name is Dr. Zach Pulliam, and I'm a second-year medical oncology fellow at the University of Louisville. Also a proud Louisville native, and here for the Kentucky Society of Clinical Oncology, or KYSCO. KYSCO is a physician-led organization whose mission is to ensure the highest standard of cancer care in Kentucky through education and advocacy. It's a free membership organization, and if you are a cancer care professional in the state of Kentucky, we invite you to join our community. On this show, we bring you along for deep discussions with your oncology peers across the state of Kentucky to bring you the latest in the community, cancer education, as well as advocacy. It's a new year, and today the latest on GI cancers and how that affects care in Kentucky. I have with me today Dr. Michael Cavnar, who is a surgical oncologist at the University of Kentucky Markey Cancer Center.
Hey, how's it going? Glad to be here.
Yeah, glad to have you here.
It's a pleasure to be here and talk about an important topic, which is GI cancers, which is my sort of main area of expertise.
Excellent. And are you from Kentucky originally, Dr. Cavnar? Are you a transplant or?
No, so I grew up in Ann Arbor, Michigan, and went to college there. And then I moved to New York City where I did all of my training. And then when I finished a surgical oncology fellowship, I moved to Lexington and took my first faculty job in 2017 at University of Kentucky.
Excellent. That's awesome. So I think our planned talk today is on hepatic arterial infusion pumps and your work surrounding that. So if you don't mind just giving us a little bit of a background on what that looks like and what they're used for.
Yeah, so the liver is a place where many different malignancies are found. And so there's really primary and secondary malignancies in the liver. And, one of the most common things that we see is metastases to the liver. And colon cancer is one of the prime causes of liver metastases. In terms of primary cancers, we see hepatocellular carcinoma and intrahepatic cholangiocarcinoma, which is a bile duct cancer. And so this is obviously a very broad area of cancers, but two of those diseases I mentioned are particularly troublesome in terms of outcomes and control of those diseases. So the colon cancer, liver metastases, and intrahepatic cholangiocarcinoma. And many years ago, they figured out that one of the ways to achieve a higher concentration of chemotherapy drugs within the liver was actually to give it directly into the artery. The liver is a fascinating organ in that it has a dual blood flow in. So about 2/3 of the blood comes from the portal vein, which brings all of the blood back from the viscera, so the intestines. And then about 1/3 of the blood comes from the aorta through the hepatic artery. And so starting, and this was really discovered probably in the 1950s, that tumors in the liver actually derive the majority of their blood supply from that arterial system, even though it's the minority of blood flow to the liver. And so that started being capitalized by oncology physicians. And so in the early days of that, there were experiments with, direct injections into the hepatic artery, done via laparotomy and open surgery. And over time that evolved. And the sort of current iteration of where hepatic artery infusion is through an implanted pump. And so we use a device that's about the size. Now I grew up in Michigan, so you say the size of a hockey puck. But if you describe hockey pucks in Kentucky, people look at you like, I don't know what that is. So I usually say a biscuit or a can of dip, and that tends to get more traction in terms of size comparisons.
Definitely could see that.
So the pump is about that big. It holds 30 milliliters of fluid. The current device that we use, which is a whole separate story, has a chamber that's filled with a gas that expands with body heat, and that heat expands the bellows and pushes the fluid through the catheter at about 1.2 to 1.4 milliliters a day. So it's a very low volume, but you're able to put a high concentration in there. And so that pump is then it's implanted and it's used for these different diseases. And when and why and how and all that are some details that we could continue to discuss all day long, in fact.
Yeah, I believe that because, as you were saying, so many different settings of malignancy in the liver, whether primary or metastatic from other primary sites. And I think you have a trial going on at UK involving these pumps, correct?
So we have quite a lot going on with these pumps. We have a national cooperative group trial open, which I'm the site PI for, and I actually just opened a new investigator-initiated trial for the pumps, and I have also completed a separate investigator-initiated trial. So there's a lot going on with this. And just to kind of fill in the backstory of this, because it's a fascinating sort of intersection of technology, complex training and therapy, healthcare systems, insurance, businesses. And so there was in the early 2000s, there was sort of a heyday of hepatic artery infusion. And this is when some of the very early data was released. And this came from largely from Memorial Sloan Kettering Cancer Center, which is actually where I did my fellowship. And there's a medical oncologist who's the matriarch of hepatic artery infusion. Her name is Nancy Kemeny, and she really spent her entire career working on this this disease and this treatment. And there were several trials that came out that were largely performed at Memorial that were very positive. And so this set off a lot of interest, and it was being done at a few other centers. And for example, there was a randomized trial for adjuvant hepatic artery pump after resection of colorectal liver mets. And this was initially published in the New England Journal of Medicine. I think it was in 1999. And the initial readout was positive in terms of the overall survival, but ultimately the long-term follow-up, even though the Kaplan-Meier curves were visibly separate, the p-value was 0.1. And so that led to a lot of sort of controversy. And another thing that happened around that time is a lot of programs just started opening up, and surgeons just said, hey, I can put in pumps because I know how to dissect out the artery that they go into. And a lot of people got pumps that maybe didn't have indication or they were mismanaged. And there was a lot of complications. And long story short, it fell out of favor after this boom in the early 2000s. And it largely stayed at tertiary centers like Memorial Sloan Kettering, Pittsburgh, a few other centers that were sort of maintained expertise in that. I then trained in this in my fellowship, and sort of around the time I was finishing fellowship, there was a big paper that came out showing a very strong retrospective, a large data set showing the potential benefits of hepatic artery pump. And what happened is almost all the fellows my year and kind of the year before and after all went out and started pump programs, and we reached this sort of a critical mass of interest nationally again. And many of us got involved in the national cooperative groups, and we actually started this consortium called the Hepatic Artery Infusion Consortium Research Network, HCRN, which is hosted by Duke and Memorial. And I want to say it's 70 plus institutions now, and we have monthly meetings, we have a case conference, and have done many things already. We wrote a whole textbook on HAI. We developed a phase 3 randomized clinical trial, which is open through ECOG Akron, and the PIs are Mike Litsky and Mike D'Angelica. And so that's kind of some of the background. There was also a whole issue with the device, which that's a whole separate story I can tell you more about that goes into how our program opened.
Yeah, definitely. So it sounds like the evidence that there's a benefit for it is there. The question is kind of in patient selection of who's going to benefit most from this.
So the answer is yes and no. So there's really good retrospective evidence. There's good prospective evidence in older studies. And, as I mentioned, after that phase 3 study had a p-value of 0.1, and there's many reasons you can discuss why it had a p-value of 0.1, big randomized studies weren't done after that. And the people who believed in it were entrenched and did it well. The people who didn't believe in it didn't do it and were naysayers to it. And so, unfortunately, what happened is the chemotherapy, advanced. That's not unfortunate, but as the chemotherapy advanced, the studies weren't repeated alongside that. And so we went from an era where 5FU was our primary chemotherapy for colon cancer, and FOLFOX became, quote, modern chemotherapy, which is no longer modern. I mean, FOLFOX has been out for a long time. But the modern study with FOLFOX, alongside pump has not been done as a randomized study. And performing surgical trials with randomized, to randomize to surgery or no surgery is incredibly difficult to do. And so we've set out to do that. So we've put together this large phase 3 trial, and it's in unresectable liver metastases that are never going to be resectable, high volume liver only disease, and patients are randomized 2-to-1 to either get systemic chemotherapy plus hepatic artery pump or just systemic alone. And it's the overall survival is the endpoint. And so, those of us who believe in pump believe that this must be done, right? I mean, there's lots of retrospective studies saying that when you compare the people who got pumped to those who didn't get pumped, the outcomes are better. But we need level 1 evidence for this. Same thing for the adjuvant therapy. So we're in the process of designing an adjuvant study as well.
Yeah, that's really interesting. So essentially, standard of care chemotherapy plus or minus the infusion pump. So what are you giving 5FU in the pump, or what kind of drug are you putting in the pump?
So the pump uses floxuridine. So floxuridine is essentially a pro-drug of 5FU. The beauty of floxuridine is it's almost completely entirely extracted in the liver. It's 98% extracted in the liver. And so the levels that you can get intrahepatic compared to just a systemic 5FU infusion are just massive. And you give that paired with systemic, usually FOLFOX or FOLFIRI. It can't be given with Avastin because Avastin increases one of the complications that you could have, which is called biliary sclerosis.
That's interesting. And conceptually, that makes sense. I know you said the patients you're looking at are liver-only, high-burden disease, metastasis, and it makes sense that you would also give systemic therapy alongside the pump and achieve some widespread distant sites of metastasis control plus the directed liver treatments. That's really interesting.
Yeah, and that's one of the things that's actually been proven very thoroughly and nobody disagrees about. That was proven in the early studies that that doing pump with systemic is better than just pump alone. As I said, as things fell out of the heyday and things were done largely at these major centers. It was very difficult for sort of the average Joe to get access to this therapy. And so the people that were getting access to it were those that either lived in New York City and they were lucky, or they lived in Pittsburgh, or they lived in LA, or they could get on a plane every 2 weeks to do that. And this is where sort of my main area of research comes in, is figuring out how to get people in Kentucky this therapy. That's difficult in this state. This state has, the geography here means that, even though someone might be, 90 minutes on a flat road away, they might be 3 hours away coming through the mountains, and they may not have the means to do that regularly. So, one of I mentioned that we opened a new trial. So we're partnering with, there's a home infusion company called Pentec. They've been around for a long time. They're a very experienced company that has filled various pumps, specifically pain pumps, so baclofen pumps or pain pumps, And they do that in people's homes. And so they had sort of the means and the experience to safely access pumps at home. So they're now have got the certifications they need to do chemotherapy in people's homes. And so what we're doing is we're essentially running a safety and feasibility trial of anyone who gets a pump here at University of Kentucky has the opportunity to enroll in this, and they can, if they select to do so, they can get their pump therapy, their pump fills closer to home. And their systemic therapy is then given by their home oncologist. And this, as you can imagine, presents some logistical burdens or some logistical details to work out, because the dosing of the chemotherapy is not just a one-size-fits-all dosing. It's very it's complex, and there's a whole algorithm of how it's dosed. There's a weight-based initial dose, and then that dose is adjusted based on the liver function tests. And it's not a straightforward dosing plan. And so one of the barriers has always been that local medical oncologists just didn't feel comfortable doing this, even if they had the expertise to access the pumps, which they don't. So now what we're doing with this trial is my partner medical oncologist actually will do a telehealth with the patient in conjunction with the local medical oncologist who's managing their systemic. So essentially, the patient sees them, they get their labs drawn. As long as everything looks okay, they get their systemic therapy, and then we do a telehealth with them like the next day. And then we order their drugs, which are then delivered and administered via the home health for the pump. And so that trial just opened. We actually haven't put a patient on it yet.
Wow, that's really interesting because like you were saying, especially in Kentucky, the logistics of getting some of these more advanced treatments done, it can be challenging. Somebody coming from Eastern Kentucky up to UK, for example, or the far western parts of the state up to Louisville, and if you can, reach them with a telehealth platform as opposed to them having to travel across the state, obviously when they're going through treatment on top of that, that's really interesting.
Yeah. Yeah, all right. So sort of the predecessor to this study was another trial that we ran, which was also a safety trial. It was actually safety and feasibility of just doing hepatic artery infusion in a rural catchment area, which interestingly no one had ever really done before. And we did, I think it's about 25 patients, 2/3 of which were from Appalachian zip codes. And one of our endpoints was, whether people missed their appointments. And we really had no missed appointments. Patients were very dedicated, but we think ultimately it was a very highly selected group of patients.
Sure.
That were able to do it with resources and transportation, good family support, and that's great. But there's a big underbelly of patients here in this state that do not have that same resource, and people who live in Hazard or that area, or way east in the state, or even into we service a good amount of West Virginia here, some of the sort of tri-state area from Southern Ohio, and so we think this is going to be a way to really help deliver this care.
Yeah, definitely. That's very interesting. So, out of curiosity, obviously this is not necessarily new technology after we went through the history of it, but kind of being examined further, particularly in metastatic disease of the liver. I'm curious what your view is on where this would go as far as treating, unresectable intrahepatic cholangiocarcinomas, et cetera, as opposed to just getting systemic chemo.
Yeah, so actually, intrahepatic cholangio, it is a sort of a bright spot in this therapy. This, unlike colon cancer, which has had quite a few different effective lines of therapy, has a lot that we can do. Cholangio has been a lot more refractory, and most intrahepatic cholangiocarcinomas are actually not resectable. If they are resectable, resection is the standard of care, and those that can get resection, the 5-year survival is like maybe 50%. It's certainly better than not, but the majority are not resectable, and that's kind of from the pathophysiology of the disease. They usually arise from the central bile ducts in the liver, and they're central in the liver, and they involve a lot of liver tissue. but they get the blood supply the same way the metastases do. And so the outcomes for pump have actually performed very nicely in comparison to historicals for just chemo. And I think some of the latest study, it was presented at ASCO maybe a year or two ago, might have been 2 years now. That I mean, the median survival with just pump and systemic was like 25 months or something like that, which is quite a bit better than historicals for just chemo, like Gemcis or even Gemcis Durva. And so that data has really been growing. Same thing, we're trying to, there are attempts to run a randomized trial to prove it, but it's, as you can imagine, is difficult. And there is a trial open. It's just a couple of sites. It's Memorial Sloan Kettering is the lead site, and I think there's a couple of other sites, but I think it's been slow to accrue. And I don't know that, it's just hard to find the right patients to get to enroll in that trial.
Yeah,
but it's a very
definitely.
and this is actually a good sort of launch point of the discussion, is that cholangio, as I'm sure you know, being a medical oncologist, is one of the most highly mutated and has one of the most targetable cancers. And I forget if it's like a third or a half of them have IDH mutations and FGFR fusions and all kinds of stuff. And so this is where figuring out, like, where does HAI fit in? And as we learn, especially in colon cancer, we're making more and more little slices of the pie that have good targeted drugs. And, I don't think HAI is going to be like the silver bullet that trumps those things. I think it's going to be, we got to figure out which slice of the pie HAI is the best for. And I think there will be a slice that it's very good for, and there will probably be another part of the slice that it's not good for. And figuring that out.
Yeah, definitely, and using it as a complement for some of the other treatments that we do, because I think that's interesting as a potential modality for treating intrahepatic cholangio. We see a fair bit of that, I would say, at U of L, and from a medical oncology perspective, they're kind of tedious to treat. A lot of the patients are already quite sick when they come in. Gemcis Durva isn't necessarily a easy thing to go through. And as much as we love our immunotherapies, they certainly come with their own toxicity sometimes too. So that'll be interesting to see how that plays out for sure.
Yeah, and in one of the challenges, actually particular challenges with cholangio, is the biliary obstruction that happens.
Mm-hmm.
And so depending on how central the lesion is, it may or may not cause biliary obstruction and need stents. And then as those, if they need stents or they evolve to needing stents, the changes in the liver function tests from obstruction can confound your dosing. So, your dosing is based on changes in the AST, the ALK phos, and the bilirubin. But if those change from your blockage, then that's a problem too. So that's one of the tricky nuances of managing cholangio. But it makes it more interesting.
Yeah, definitely.
Yeah, you mentioned immunotherapy, and that's actually kind of right at the top of one of our lists of like safety data that we need to acquire. In that, like, we've got lots of good data for using Gemcis, or we actually usually use gemcitabine oxaliplatin because the schedule is a little easier. But there's not safety data that exists for Gemcis Durva or Gem Ox Durva, or one of the other immunotherapies. And so that's actually one of the things that through our consortium we're working on, at least creating a registry, because there are people out there doing it. It's just in small numbers, and it should be safe, but we need to show that before we start doing it large scale.
Yeah, no, definitely. I think conceptually it makes sense that would be safe. I would expect similar safety profiles between the two, but definitely needs to be demonstrated before we start rolling it out and using it on a lot of people for sure. All right. Well, unless you have any other points, I think this was a fantastic discussion.
Yeah, I think the biggest challenge I think we're facing right now is making sure that we're advocating for the right research that will get this really great therapy to the correct patients. And I think in the past, it's been probably over applied and done for patients that weren't well selected. And so I think our job as the surgical oncology and medical oncology communities is to promote these trials, but do it in a really academic way. And one of the problems we've seen is patients desperately want something, and they want a therapy and they want to be cured. And so usually the most aggressive option sounds the best. And so that's one of the reasons it's been hard to put trials together, because people come and they say, I want the pump, I have to have the pump. But we really need to get this level 1 evidence, because right now I think there's very good equipoise for the studies that are being designed.
Definitely. And we want to make it available to the people that are going to benefit from it, but not subject those who aren't going to benefit from it to it. Because, of course, everything comes with risks. So excellent. Well, Dr. Cavnar, thank you so much for your time today and for this discussion. And, of course, to our listeners, thank all of you for following along for KYSCO Oncology Voices, a resource for KYSCO. Is there a topic you want to know more about, legislation you'd like to discuss, or resources we're missing? We want to know. Drop us a line at blawrence@KYSCO-oncology.org. That's BLAWRENCE at KYSCO-oncology.org. Plus, make sure to head to this episode's show notes for more on what we discussed today, and tap the follow button in your podcast app so you know when we drop new episodes. Join us next time for more. We'll see you then.